Previously, we talked about compression fractures and what they are. Today, we're going to talk a little more specifically about what the definitive treatment is if you or your loved one is not responding to conservative treatment. And I guess the first thing to talk about is why wouldn't somebody respond to bracing and anti-inflammatories? And the reason is, by definition, this fracture happened because the bone is not normal. And we call these fractures pathologic fractures. Pathologic means disease, and a pathologic fracture is a fracture that happens because of some sort of disease process. So if you fall and break your hip, that's a pathologic fracture, because most people won't break their hip when they fall, but if you have thinning bones, you will. If you fall and you have a compression fracture, that's a pathologic fracture. And what happens is this bone is not normal, it doesn't have normal blood flow, and it doesn't respond the way normal blood flow, normal bone does. So let's say you're 35, you have a big accident, you have a fracture of your spine, you haven't done any ligamentous damage, you can be braced over the long term and you're going to get blood flow to the area and the fracture is going to heal. If you have abnormal osteoporotic bone, the blood flow is compromised, the bone density is not normal, these things just don't heal most of the time. So what happens is, I'm going to show you a little bit of a demonstration here. This is what we call the vertebral body, and you can see that this thing is slanted downward. Let me just show you an example of what it should look like, and I hope you can appreciate that this vertebral body should be very square and should be tall and symmetrical. With a compression fracture, this thing will wedge downward, and that's what causes this forward stooping in the elderly population with these issues. So here we are, this thing is stooped forward, and you can see that the bones have buckled on the outside. And this is where that periosteum is that's extremely painful. What we want to prevent is we want to prevent this thing from wedging down even more and causing a big deformity in their posture. We want to control their pain, so we want to solidify this thing so that it's not sloshing around and that they can get around without these bone fragments moving, because these bone fragments are literally moving around every time they take a step or take a deep breath. And the last thing we want to prevent is retropulsion. So just, I hope you can appreciate that there's a wall back here. It's called the posterior cortex. If this thing keeps wedging down, it can actually break backwards through this cortex, and this is where your spinal cord is. So the three things we want to prevent are progression. We don't want this to progress and cause a deformity in their posture. We want to prevent their pain, and we want to stop that retropulsion. So let me show you this next piece. This is that same compression fracture. We numb the skin, and we place a trocar here that goes through a structure called the pedicle inside the vertebral body. And this is where we inflate those balloons, which hopefully elevates the height a little bit. But what it does is it makes a nice void for the cement to go in. We don't want the cement to go backwards. We want it to stay right here. And your best repair is one that goes all the way across the vertebral body. So we introduce here, we put in balloons. And the other thing I want to emphasize is that when we put this trocar in our clinic, we always take a biopsy of this thing. Well, we have to be wary that this could be cancerous. And I have caught many patients initial cancer diagnosis with a compression fracture. So all of our patients get a biopsy for this procedure, and you should make sure if your loved one has this that they do as well. So we biopsy, we put in this balloon, we create this void, and then finally we fill that area with cement. And this cement, as long as it goes across the middle to both sides and it stays in the front, it'll dry in 9 minutes, and the patient should have significant pain relief that day, and over the subsequent week should be back to their baseline and then able to wean off their pain medications. And again, the reason we do this in an older person with osteoporotic bone is that it's typically not going to heal properly, and we don't want that thing to pancake all the way down, because we don't want those poor people to be stooped over for the rest of their life. And the worst thing we want is this thing to continue to bend over and then break out this back wall. That's called retropulsion. Once that thing retropulses, the patient's got compression against their spinal cord. They're not a candidate for surgery because they're not going to heal well. They can't get the proper fusion because their bone quality is poor. And it's a really tough situation. It can be an end-stage hit to these people because they don't have a lot of reserve. The procedure takes about 45 minutes. It's quite safe in the hands of people that have done it. quite often, and you can get these patients feeling a lot better and off their medications. And then once we do that, we really start focus on balance training. We typically get some home health for them so that they can get around better, and we want to get them back to their baseline as quickly as possible. We want to get them off their pain medications and going out, walking the dog, going out gardening, and getting back to where they were. And then emphasizing that this is a risk going forward. Once you've had one compression fracture, you're prone to subsequent ones. So we got to get our osteoporosis treated. We've got to work on balance training and avoid activities that could potentially cause another one of these. Hope that was useful for you, and look forward to doing some more videos for you in the future.